Okay. Well, thanks very much. We're going to switch gears and talk about some younger patients now. So we'll go over the infant hip exam. We'll talk a little about the definition of hip dysplasia, the epidemiology, to give you some of the clues that you might need to raise your attention on your exam for a patient that might have an abnormal exam. We'll go through some of the steps and referrals of the exam itself, as well as the messages. As I'm sure everyone in this room knows, developmental dysplasia of the hip is a condition characterized by a shallow sock with an undercovered femoral head. It's a bit of a misnomer because we call it a dysplasia, but that's usually a condition where there's a problem with the cells themselves, the embryologic period, but this is really more of a malformation of a normal structure. And it represents a really broad spectrum of disease, ranging from physiologic immaturity, where the socket and ball are not quite normal, but just a little behind in their growth, all the way through subluxation and dislocation. The incidence of DDH is about 1 to 2%, depending on the study and population that's used. And a dislocated hip is about 1 in 1,000, so much more rare. We're referred about 4 to 5% of births, either due to risk factors, which we'll touch on in the next slide, or an abnormal exam, but only about 4 to 5 kids out of 1,000 are actually treated. But we're very happy with that ratio. Because here in the US, as opposed to some other countries where there's a standardized imaging protocol for screening, we have a universal physical exam for our screening. And so we want you to have a low threshold so that we can identify those kids early rather than identifying late detected dysplasia, which is much harder to treat. The risk factors, as we commonly teach, are the 4 Fs, right? Being female, which is 80% of cases, firstborn, having a positive family history, which confers a 12-fold increased risk, and then being either feet first or breech, which in the literature is pretty broad risk profile of either 2% all the way up to 27%. We published here in our Scottish Rite experience that it was about 25% of the infants referred with a breech history were dysplastic. And I think that's part of why the American Academy of Pediatrics updated their screening guidelines to say that not only females, but also males should be screened with imaging. In terms of the physical exam itself, I think the most important point is that everyone has to be calm. This is a really gentle exam. So we have orthopedic residents who tend to be bigger than me, and we really emphasize this is a really subtle exam. You have to look for subtle clicks or clunks. And so baby needs to be calm and quiet. If they're fussy or fighting you, then you're not going to appreciate those subtleties. I certainly will step out of a room if baby seems really upset and give family a chance to feed or soothe their baby. We can go see another patient and come back, just because you really need to get a calm exam. When we think about the different options of hips, we have a normal stable hip on exam. We have an unstable hip that may not be fully dislocatable. This is where we talk about things like pistoning, where it seems like that femoral head can move a bit within the acetabulum without actually dislocating. And then we have a hip that maybe rests in a reduced position, but can be dislocated. So you can feel it clicking or clunking out of the socket, which is a Barlow positive hip. And we'll go over these maneuvers in the next slides. Then you have a hip that's dislocated in its resting position, but you can reduce it in the socket. That's the Ortolani positive hip. And finally, you may have a hip that you can tell, and we'll go over these clues on exam, is dislocated clinically, but it's in a fixed position, so you can't manipulate it back in. And most of these hips, if they remain unstable, ultimately become a fixed dislocation, usually by a few months of age, because the muscles, the capsule, all those soft tissues have contracted down over time. So even though I just gave you 5 discrete buckets for patients, they clearly don't actually follow those rules, and the findings represent a spectrum. So we look for a variety of different things that may all clue us in that there's actually dysplasia. On the right, in the top right, you can appreciate that there's asymmetric thigh folds. The idea there is that when a femoral head is subluxating or dislocating proximally, the bone's moving up, but all of those soft tissues are accordion down, for lack of a better term, and you end up seeing more thigh folds on that side compared to the other side. We're very happy to screen those patients. In general, that's a relatively non-specific finding to see, 1 extra fold on the side you're worried about. A much more sensitive finding is limited abduction of one hip compared to the other. The Galeazzi sign, as you see on the bottom, is when that femur appears to be shorter than the other side because the head, again, is dislocating proximally. And that's the same reason why, unfortunately, we meet some kids when they're already walking age for a limb discrepancy. Talked about the idea of pistoning in an unstable but maybe not dislocatable hip, and we'll look at example of Trendelenburg gait. So our Barlow positive hips are the ones that rest in a reduced position, and there's great dolls outside, and then we also have our live exam with an infant. But essentially, I'd like to hold the thigh so that the knee is flexed, my hands around the front of the knee, as you can see in the picture, and you flex to 90, deduct towards midline and provide a posteriorly directed force, and you'll feel the hip click or clunk out of the socket. At rest, the hip will go back into the socket, which is why it's a Barlow positive hip, because it rests in a reduced position. Conversely, an Ortolani positive hip is resting dislocated. So instead of adducting towards midline, we now have the hip flexed and progressively abduct. I like to have my long finger on the greater trochanter, and I can provide an anteriorly directed force on the hip as I'm abducting it, and you can feel that hip click or clunk back into socket. This feeling is typically lost by a couple of months of age, again, as those soft tissues contract. And so it's important to really try and feel in a subtle, calm exam if that finding is there, for an earlier referral so that we can increase our success in treatment. This is an example of here we go. This is an example of an older infant, like a year or so, that we're in the operating room for a close reduction. You can see the hip is out, and then as we adduct, it pops out, and that's popping back in. So you can usually appreciate that there's a significant click or clunk there. Ultimately, if the hip remains out, it's going to become a fixed dislocation, dislocated and non-reducible. So what findings will you see there? Well, you'll see asymmetric thigh folds, as I highlighted before, limited abduction, again, the most sensitive finding, a positive Galeazzi sign, and in older patients, a Trendelenburg gait. We highlighted the Galeazzi test. Here's the Klissick test, where you draw a line with your fingers between the greater troch and the ASIS. It should pass at or above the umbilicus. As the femur migrates proximally, it passes below. In older patients, we can see a Trendelenburg gait where their pelvis drops away from the leg they're standing on, or they lean their trunk over the top. This is a 15-month-old who came into clinic for gait disturbance or limb length difference. You can see she leans over that right hip as she walks. And sure enough, her right hip was dislocated on the plain films. In patients with bilateral dislocations, you also see sway back deformity, exaggerated lordosis, like in this girl. She's got bilateral dislocations, and so she has a Trendelenburg bilaterally, which is a waddling gait. Family used to call her penguin as their term of endearment. So our take-home messages, DDH represents a spectrum of pathology, so you can't look for just one take-home exam finding. But your antenna should be up on patients who are female, firstborn, feed first or breech with a positive family history. I'd be happy to talk, although it doesn't fit into this lecture, on hip clicks during the Q&A session, because we recognize that's an increased risk of dysplasia. A calm, relaxed baby is essential. And again, you're looking for clinical findings that represent the spectrum of pathology that exists, although limited adduction is most common. Thanks so much.
My name is Will Morris, and I'm a pediatric orthopedic surgeon here at Scottish Rite for Children. Today we're going to be going over the infant hip exam from toes to nose, and I'm joined by baby Tommy, who is an excellent patient for us today. So please join us as we go over some of the subtleties of the hip exam, and then we'll also have a chance to go over some of the common questions that we get from pediatricians and family medicine physicians. Okay, so today baby Tommy has been kind enough to help us out with our infant hip exam. And so we're going to talk a little about what we do when we do our exam, kind of from toes up to nose. But we're going to start first on the hip exam, because that's the most important part, and really where you really need your infant to be calm and relaxed. If the baby is tense or upset, it's really hard to get a sense for some of the more subtle clinical findings. And so we're going to start there. And that really starts with inspection. So, it is important that you have the infant undressed enough that you can really look at their skin, because the first thing that we look for are things like asymmetric thigh folds. So you can see Tommy has symmetric 1-2 folds on the left and right sides. In a baby who has a hip dislocation, when that hip is dislocated proximally, so if this femur was further up, then what happens is, since the femur is driven out posteriorly, you get a cordoning of the soft tissues, and you see extra folds on the side that's relatively shorter. And so when we look at Tommy, we can see that the skin looks very symmetric side to side. That can be one of the clues that you may see, although we'd say it is not a very specific clinical finding, meaning that just seeing that alone does not highly predict that there's dysplasia. It's just one of the many signs that we can see. One of the most common signs in hip dysplasia is actually limited hip abduction. So when we bring Tommy's hips out to the side, we can see that both sides widely abduct, and looking from the bottom, both sides widely abduct to maybe 70 degrees or 80 degrees, and that's very normal. Tommy has excellent hip abduction. In infants that have hip dysplasia, what you may see instead is that one hip is a little tighter and abducts less. So limited hip abduction is one of the most common findings when we think about what are we most likely to see in an infant that has hip dysplasia. It's limited hip abduction. Other things that we can see is when we flex the hips up, and this is another good thing to see kind of looking from the bottom of the bed, when we flex the hips up, both thighs appear to be the same length. Okay? In an infant who has, for example, a left hip dislocation, because that proximal femur is resting out of the socket, that side can look a little shorter, which is called a positive Galeazzi sign. So when you see one hip where the femur appears to be a little bit shorter, that suggests that maybe that femur is resting out of the socket, which again, if you look at the position of the knees, that leg will look shorter. So unfortunately, we meet some infants when they're a little bit older for concern for a limb length difference, but really what you're seeing is that hip is dislocated, the femur is riding proximal, riding up, and it makes the leg look shorter. We have some provocative maneuvers to test the stability of the hip. Those two maneuvers are the Ortolani maneuver and the Barlow maneuver. And we're going to overlay some images so you can see what we're trying to illustrate. But the Ortolani maneuver is for a hip that is resting in a dislocated position and you're reducing it, while a Barlow maneuver is an exam for the instability of a hip that rests in a reduced position and you're pushing it out of the joint. So for a Barlow maneuver, the hip is in, and then by flexing the hip up, adducting it towards midline and pushing out posteriorly, you can feel that hip sliding out. So in general, what I try to do is I flex the patient's knee and I have my finger on their thigh by their greater trochanter, which you can feel here on Tommy. And you flex the hip up, bring it towards the midline, and you're pushing posteriorly. You may feel a clunk in that case, which would suggest that you're feeling the hip driving out of the socket. But when you relax, the hip will come back in because it rests in a reduced position. Conversely, if you have a hip that's dislocated, by abducting the hip and putting an anteriorly directed force on the femur, you can feel sometimes that hip click into place because it was resting dislocated and you've just reduced it. This is an Ortolani maneuver. So by pressing the hip out, if you feel a clunk, or if by abducting the hip you feel a clunk, it suggests that the ball is moving in and out of the socket, and that suggests that there's hip instability. This is an example of a patient, if you feel that, where they should be referred immediately for evaluation. Just like if you see a Galeazzi sign, or if you sense that there's limited abduction. So all abnormal exam findings that prompt further evaluation. So one of the common questions that we get is about the hip click. And the idea is that you're doing the Barlow or Ortolani maneuvers, and you sense that maybe there's instability of the hip. Sometimes a click is really just a soft tissue click because there's so many muscles that cross the hip joint. However, and particularly in smaller infants, it may be difficult to appreciate whether you're feeling the hip joint coming in and out of socket or whether it's just a soft tissue click. And although the American Academy of Pediatrics doesn't specifically recommend imaging or screening for these patients, when we've studied this patient population of patients who were referred for hip clicks, we actually found that about a quarter of them had some hip dysplasia and 5% had a severe hip dysplasia that would be consistent with hip instability on ultrasound. So we actually advocate for all of those patients where you have that concern, where you're wondering, is that just a click or is it a clunk of the ball moving in and out of the socket, to go ahead and refer the patient for imaging and further evaluation so that we can make sure we capture all of those patients who have dysplasia to treat them appropriately. In Other patients, particularly as you get to be a little bit older, the instability of the hip moving out with an Barlow maneuver or in with an Ortolani maneuver will start to decrease, and you'll end up with what's called a fixed dislocation, meaning the hip is dislocated, but you can't appreciate it moving in and out. So how do you identify that patient? Well, we've talked about the Galeazzi sign, where that leg will look a little shorter. Limited hip abduction, where that hip won't abduct as widely on the affected side as the unaffected side, but you won't have a positive Barlow Ortolani maneuver. And that hip can still be dislocated, particularly in older patients, because the soft tissues have begun to contract and hold that hip in the dislocated position. So you have to look for these other signs. And if you see, again, limited abduction, positive Galeazzi, that you may still have the suspicion, even though you can't feel the hip moving in and out. In patients with, I'm going to undo just the top of the diaper. In patients with bilateral dysplasia, specifically with bilateral dislocations, it can be very challenging to identify asymmetry. Perhaps both hips have limited abduction, and you sense something's not quite right, but you can't put your finger on it because there's not a difference side to side. One of the other clinical exam findings that we can look for is what's called the Klissick test. So if you put your finger on the greater trochanter and your finger on the anterior superior iliac spine, a line that connects them should pass at or above the umbilicus. In a patient with a hip dislocation, that greater trochanter rides proximally, and consequently, a line that connects the greater trochanter, which is now relatively high, with the anterior superior iliac spine, as an example, would then pass below the umbilicus because the hip is dislocated. And so you might see that positive on both hips because both hips are dislocated. So that's an example of a test you can use if you sense that, for example, there's limited abduction, or I'm concerned that there's maybe disease on both hips, but you don't have a clinical test. Whenever we see infants for our newborn hip exams, for example, a baby who's referred for being breech, we always examine the patient from the toes all the way up to the nose to look for other orthopedic manifestations, and this is part of our infant hip exam. And so we started with the hips because Tommy, who's been an incredible sport for the first few minutes of our exam, we wanted him to be relaxed, and he did a great job, so we could really feel that he fortunately has nice, stable hips. However, now we want to go back and we want to check everything else to make sure they don't see any signs of other orthopedic manifestations of musculoskeletal disease. So we take off the socks every time to make sure that we have a nice plantigrade foot position, okay, that dorsiflexes nicely. We can see that he has a little bit of an arch. He's curling his toes just a bit. So he has a nice arch. We don't see any evidence of, looking from the bottom, a varus of the foot, for example. A varus foot that has an exaggerated arch or perhaps forefoot adductus would be reflective of a clubfoot type position. And conversely, a foot that's in valgus and in calcaneus can suggest a calcaneovalgus foot position, which is an example of a packaging disorder where you're maybe pushed up against the uterine wall. Both of those are conditions that we're happy to evaluate the patient for and can follow for resolution or for treatment in the case of a clubfoot. You look for active knee extension when the foot is not in the mouth. Yeah. We look for active knee extension. And so you can kind of stroke the leg and see if you can encourage Tommy to kick. Yep, and I stabilize the thigh when I'm doing that so we can see that he's not just extending his hip and straightening his knee out that way, but actually have the hip up. You can make sure that he can actively extend. We also want to check for any evidence of spinal dysraphism. So you're looking for tufts of hair, sacral dimples, pitting around the sacrum. So I usually turn the infant towards the parent so they feel like they can look at someone safe. And you look down by the gluteal cleft, and you can see here that there's no evidence of a tuft of hair, any skin changes, or pitting. We can see the floor of that gluteal crease. You can similarly look at the back and make sure you don't see any evidence of scoliosis or spinal deformity. When we look at the hands, we want to make sure that the palms can open. There's no evidence of a clasped clasped thumb deformity on either side. And then the last thing I do, because children tend to yell at me when I do it, is I check for evidence of torticollis, or limitations in neck range of motion, typically from a tightening of the sternocleidomastoid. So we're going to look and see if Tommy can rotate his head all the way towards mommy, and then we're going to have him look all the way the other way. Good job. And so there's no evidence of any limitation there. So that's our toes to nose exam, which I do again after I've examined the hips, because I prioritize that because he has to be relaxed for that exam, so you can find some of those subtle findings like Barlow and Ortolani positive tests. And I think that sums it up. And we'll go over to the Q&A after this.